Okay, hello. So we're going to start tonight with tonight and at the next class meeting. We're going to talk about um, psychotic disorders, and tonight I'm going to do a lecture specifically on the the pharmacology of schizophrenia. So we'll start here, and then when we pick up on the next class, we'll talk about other types of psychotic disorders and some other issues related to psychotic disorders. So I have I have some slides I want to share tonight, and I will pull those up right now. And let me put this on full screen here, and let me see what I can do about full. Yeah, there we go. Okay. So one thing to keep in mind, these are slides based from a psychopharmacology presentation on schizophrenia, and they're a little old. They're 2014. They're from some slides I have from 2014, but I like them because they not only talk about um, psychopharmacology of schizophrenia, but they also talk about um, they also talk about dopamine and some of the dopamine pathways in the brain, and I like that. I like that we would have the chance there to address to look a little bit deeper into this whole idea of how dopamine is developed and processed in the brain. So, the psychosis. Now, we're specifically talking about schizophrenia with this presentation. But psychosis is specifically described as a syndrome of chronic disordered thinking and disturbed behavior. And there are a number of even though this presentation is about schizophrenia, it's useful to keep in mind that what we are looking at here is not only schizophrenia, but also what the different types of psychoses have in common. So we will address that. We will address not only uh, schizophrenia. I mean, this presentation is primarily about schizophrenia, but what we talk about with schizophrenia also applies to the other psychotic disorders, which can include depression. As you may remember from a discussion we've had of psychopathology, there is such a thing as major depressive with psychotic symptoms. Psychosis can very often be associated with major depression. So, okay, and then we'll schizophrenia specifically is a chronic mental disorder involving a breakdown in the relationship between thought, emotion, and behavior, leading to faulty perception, inappropriate actions and feelings, withdrawal from reality, personal relationships into fantasy and delusion, and a sense of mental fragmentation. It's characterized by a divorcement from reality in the mind of the person. So the person is no longer connected to reality, at least in their own mind. And that's what schizophrenia is. In a way, so this condition, a divorcement from reality in the mind of the person, is what is known as psychosis. Now, the difference between pretty much what you're talking about is different disorders can have psychosis associated with it, or some form of psychosis associated with it. But schizophrenia is the disorder where this is the predominant symptom. So psychosis and schizophrenia are not synonymous, but there is no disorder in the DSM-5 called psychosis. There is a disorder called schizophrenia, and there are other disorders that have psychosis associated with it. But the one disorder where psychosis is the predominant symptom is schizophrenia. This is kind of a general breakdown of how schizophrenia develops. The person starts with a genetic predisposition, and then there are environmental, social, and psychological factors. These three things kind of start the whole process off. The person is born. So basically, what this shows here is the genetic predisposition can lead the person to develop neurodevelopmental abnormalities and target features. So these two are directly connected. But not everybody, even with the genetic predisposition, develops schizophrenia. You have to have this other part as well: environmental, social, and psychological factors. So unless these two things combine, this won't really matter, or it may matter to a certain degree, but it will not matter in terms of the person developing full-blown schizophrenia. You have to have both. You have to have the genetic predisposition and the correct environmental, social, and psychological factors. This is years ago, decades ago, the prominent theory of why schizophrenia developed was a psychoanalytic theory called refrigerator mother. And what it meant was schizophrenia often developed because in children whose mother was whose mothers were just very, very cold, like very distant and very unemotional and very unattached. That was always limiting, in part because it didn't cover every person who had schizophrenia, and it took into account even the idea, because certainly having an emotionally distant mother, a very emotionally distant mother, or emotion, as we would probably call it now, an emotionally distant attachment figure. So it could be mother, father, it could be guardian, whoever was primarily responsible for raising the child. Having someone who is very, very emotionally distant certainly could be an environmental factor that could contribute to a person developing schizophrenia. But unless this genetic predisposition is also in place, the individual will not develop the neurodevelopmental abnormalities and target features that make up that lead to schizophrenia. So you have to have both these things. And then what ends up happening is this starts a process that leads to this, and then this leads to a chemical imbalance, what's called here an improper balance of chemicals. Brain dysfunction due to this improper balance of chemicals, and that's what leads to the development of schizophrenia. So you have to start off with these two things, and then it leads to the development of schizophrenia. Okay. Now, I'm not gonna. I just we'll start off with the discussion of this. So there are four major pathways for the dopamine, basically the dopamine system in the brain, and these are named. So what these are terms I want you to see, and I think they're important. These are four major pathways in the brain that contribute to the development of schizophrenia. But notice one thing I just want you to really pay attention to here. Notice what we're looking at here: dopamine. Dopaminergic means systems that are responsible for the level of dopamine in the brain. And here's a picture of it. I want to. Let's just look at the dopamine. So here are the dopamine pathways. Notice how they're they'll cover sort of these areas of the brain. And you can look here at the different areas of the brain. So you in the in any neuropsychology course, you would recognize some of the terms of the parts of the brain that are involved here. This substantial nidra, the amygdala, the hippocampus, the prefrontal cortex. These are the areas. Now it's interesting here that these two areas involved, but this is the area that really causes a lot of this really plays a major role in it. Let's look at this little section up here. Dopamine is a neurotransmitter used by the reward pathway, basically associated with this area down here, the reward pathways. So any drug that affects dopamine level is affected here. And the reward pathway means this is how, so this whole idea of how of what we find rewarding, of what we do, of what motivates us to do things is really associated with this pathway here. And hallucinations and schizophrenia can develop along this pathway, like it says, if not functioning properly. Let's look at the dopamine hypothesis. This is the dopamine hypothesis of schizophrenia. Schizophrenia results from excess activity of dopamine in these areas. So basically, the idea is that excess dopamine in this pathway right here leads to schizophrenia, or that's the dopamine hypothesis of schizophrenia. So here you're talking about too much dopamine. Remember with depression, we were talking about too little dopamine, and here we're talking about too much dopamine. And what are and that's from research that has shown higher levels of dopamine receptors measured in brains of schizophrenia using PET scans. Amphetamines, which act through dopamine, can produce schizophrenic like behaviors. So with schizophrenia, you have the positive symptoms. These are the ones that are the more active. So there are positive and negative symptoms of schizophrenia. Well, negative symptoms. The positive and negative symptoms. I mean, the positive symptoms of schizophrenia involve those that are more active: the delusions, hallucinations, combativeness, and insomnia. And negative symptoms are flat affect, lack of motivation, lack of energy, and not antisocial behavior, but just asocial behavior, meaning showing no concern whatsoever, no motivation for social interaction. Now, notice these are terms often used in describing schizophrenia, and notice that they are the terms used are positive and negative, but not positive and negative in terms of good or bad. Positive meaning, one thing I'd like you to keep in mind, because it is a term you hear a lot in schizophrenia, positive symptoms in schizophrenia mean active, things that are actually happening. And negative symptoms mean lack of something, lack of energy, lack of affect, lack of social behavior. There's also disorganized symptoms, disorganized thought, speech, and behavior. So So what ends up happening with antipsychotic drugs, antipsychotic medications? Antipsychotic drugs reduce psychotic symptoms in schizophrenia, but also psychotic symptoms in psychotic depression, bipolar disorder, and drug-induced psychosis. This is a term, this is a useful thing to keep in mind. They're called neuroleptics because they suppress motor activity and emotionality. So they basically work on, they basically combat these. They do not combat these so much. They combat these, they sort of suppress these more active symptoms. They're not a cure. Psychotic diseases are considered to be lifelong and are used to help prevent psychotic episodes as a way of helping the person not develop psychotic episodes. So, and sort of the bottom line here that they get at is it is preferable to prevent psychotic episodes than to try to treat psychotic episodes. Here are the names of some very common antipsychotic medications. Let me just throw out a couple here. This is Haldol, and this is Thorazine. So you got Thorazine, you had Haldol, Risperidone, also known as Risperidone is also known as Risperdal. So these are the generic names of them. Like I said, ones you may recognize: Thorazine, Haldol, and Risperdal. There are, notice back here that these are called typical and atypical. Here's the difference between typical and atypical. Typical tend to have less side effects. Typically, very traditionally, you would go with typical first and then atypical. Atypical tends to be more, basically, atypical developed because typical antipsychotics were not useful in all cases. So atypical came up to really help to address treatment-resistant patients. Now, the one thing though about atypical is they're more atypical antipsychotic agents are more effective against negative symptoms. So if you go back here, so it's interesting to keep in mind. One thing to keep in mind, even as a psychologist, if you're working with individuals who have schizophrenia and are taking medications, one thing that's useful to keep in mind is that if they are on the more typical psychotic, if they are on the typical antipsychotic, and typical I mean not only just by the name, the one meaning typical, the ones that are typically used, like these ones. Hold on a second. So if you have someone who is on Haldol or Thorazine, two very common antipsychotics. Haldol probably the most common, so let's start there. If you have someone using it, one thing to keep in mind is those tend to be more effective. Those are medications that are targeting primarily these. So, because these are seen as the primary problematic symptoms, these are the ones that are seen as reflective of the disconnect from reality. This is seen as the main reason why why schizophrenia is a problem, is because of these symptoms. If you then if you use medications that for some reason you have decided to go with the atypical antipsychotics, they will still target these, but they also tend to more often target these as well. Not as much as the positive ones, but they have more of an effect on these than the typical. So it's just interesting to keep in mind that with antipsychotic behaviors, the things that are that the medication is targeting are more the distinction from reality. But very often, as a therapist, you may be working with someone who for whom the medication has helped lessen the psychotic, what is typically thought of as the psychotic symptoms, but has not actually done much here. So that's often why the therapies for schizophrenia, the psychotherapies, tend to be ones that are geared more towards helping the person develop more social relationships, helping the person be motivated to find things that interest them, to get motivated in doing things that they find enjoyable or particularly that they find meaningful. That's why the therapies often focus on this, because oftentimes and also to make better decisions about what's going on, to pay better attention to the decisions that they're having to make. It's because the most common antipsychotic medications, the typical antipsychotics, don't target those symptoms much, don't target the negative symptoms. They target the positive symptoms more consistently. The atypical antipsychotics like Risperdal do target them some, but not completely. So just bottom line is, what you want to keep in mind as a psychologist about antipsychotic medication is they tend to address the more active symptoms, otherwise known as the positive symptoms, the ones that are more reflective of the person being quote unquote disconnected from reality. But they do not tend to impact on the symptoms that could cause some real difficulties for the person, lack of motivation, not wanting to do things, lack of energy, all that sort of thing. So some of the areas that the antipsychotic medications, they target all these areas, even though so they target some receptors that have to do with serotonin, but these are more secondary, even tertiary, even second and third importance. This is the one that is most important. Okay, and these are just some information. It's interesting to keep in mind that some of the typical antipsychotics are used. They're used for schizophrenia. They're also used for treatment of nausea and vomiting, like severe nausea and vomiting, and also as an anesthesia. So it's interesting to keep in mind that the medication used for schizophrenia also, because of their effect on the dopamine systems, can be helpful in treating severe nausea and can be used as an anesthesia. Very important to keep in mind when you're dealing with anybody who's on an antipsychotic medication are the side effects, because there are a lot of them, but the primary ones can be very severe. So I don't know why on these slides, just to point out, they often describe that one of the types of side effects is Parkinson-like symptoms. I put them down as separate, but you could make the argument that this is what this is. Tardive dyskinesia is a severe disorder caused by the use of antipsychotics that has with it Parkinson-like symptoms. So involuntary movements of the face. So Parkinson symptoms are involuntary movements, but they're more like tardive dyskinesia goes a step further. Tardive dyskinesia, not only the involuntary movements that can look like shaking, they can also involve movements of the face, tongue, and limbs. So Parkinson-like symptoms would be involuntary movements of the limbs, but then you've also got with tardive dyskinesia, involuntary movements of the face and tongue. So the person, maybe the tongue darting in and out, maybe facial twitches along with twitching of the limbs. Neuroleptic malignant syndrome, I mentioned this earlier in class, or in an earlier class. This is a disorder where basically the person's temperature regulation system shuts down. So it can be terminal because the body loses its ability to regulate temperature. Seizures can be associated with the use of antipsychotics. Very, very low blood pressure can be associated with it. These are some other medical side effects. It can cause antipsychotic medications. It can cause infertility. It can cause an increase in urine volume. So very often people on antipsychotics have to urinate a lot. A rare problem is skin reactions, skin problems. And no, here's what I'd like to see. Well, let me do this. Okay. Notice what happens here. Notice this is one. Okay, so these are other side effects: dry mouth, constipation. But here's what I want you to understand about the psychopharmacology. Now it doesn't matter. These are specific types of neuroreceptors. But notice what happens here. These. So what ends up happening with? I want to go back. In order to understand side effects and why you have side effects and why the more severe, here's what I wanted to show you. Why you have side effects and why the more intense the symptoms that are being addressed, the more likely you're going to have side effects is because of this. Look what happens here. Now you've got these are the typical antipsychotics. Now the problem, as far as the theory goes, of what leads to schizophrenia, is that these receptors need to be targeted. There's too much dopamine in the brain, so these need to be targeted. But notice, these are also being targeted. Okay, now these, in reality, have very little to do with schizophrenia. There's no theory. Serotonin, when you delve into the dopamine theory, there is some thinking that serotonin can be involved as well. But the rest of these, but these ones here, you take this one out because this is mentions dopamine. But you take these three over here, and you're starting to get into receptors. So just look at how many receptors here. Not all of them directly relate to schizophrenia. They are impacted because the medication isn't perfect. So the medication addresses these, but at the same time addresses these. That's why you end up with side effects, because you've got all sorts of different parts of the neurochemical system being impacted, um, um, even though they have nothing directly to do with schizophrenia. It's just the way medications work. They're imperfect, especially ones that are going after more severe symptoms, symptoms that are not as well understood, um, symptoms that are considered um, uh, just very difficult to understand, very difficult to explain. So, because you have symptoms like that in schizophrenia, as a result, you end up with a medication that addresses a lot more areas than the ones that are directly involved in the disorder. Um, Here's some of the limitations of typical antipsychotics. Approximately one-third of patients with schizophrenia fail to respond. Like I said, limited effectiveness against the negative symptoms that we talked about. But the relapse with the typical antipsychotics, side effects. Um, and so the atypical ones, which actually are the newer ones, are often, it says are preferred. My impression is that um, Haldol, one of the typical antipsychotics, is still the most widely used. But you have the atypical, which Risperdal would be one, um, that are becoming more and more popular. Again, because it addresses uh, the patients who don't. It's still, here's the thing about typical and atypical antipsychotics. The atypical address the one-third who fail to respond, while also still helping most of the two-thirds that do respond. So it's not like the difference between typical and atypical is that the atypical helps this one-third, but the typical helps the other two-thirds. That's not the case. Atypical helps more of this one-third of patients who fail to respond, while also at the same time still showing effectiveness for most of the two-thirds that respond to typical antipsychotics. So basically, atypical psychotics become more and more popular just because they are seen as being capable of helping more and more people and also addressing more symptoms, and because of this negative symptoms. Um, like I said, some of the benefits uh, atypical is lower side effects. Did I say anything else here? Low, so here you've got, now here they're talking about clozapine. That's one of the atypical. Risperdal, like I said, that's Risperdal. It's actually, Risperdal is seen as the antipsychotic that has the least problems with side effects. But one side effect is its increased risk of stroke in the elderly. So Risperdal is often seen as one that you want to at least be careful in terms of using with elderly patients. Interesting thing about Risperdal, which is the brand name of this, Risperdal was the only psychiatric medication approved by the FDA for use in autism, and it's approved for use in autism to address a specific symptom, namely violent behavior. And Risperdal is also seen as a particularly effective medication in schizophrenia for helping violent schizophrenic. This is just so interesting again. Well, hold on a second. One of the they didn't. Okay, one of the I'm sorry. One of the medications, one of the atypical is called chlorpromazine. And that's an antipsychotic. It's also used to treat intractable hiccups. That's an interesting side effect. It's in medications when people have violent hiccups that they just can't stop, this is the medication that often is used to treat it. Risperdal and Haldol are also often prescribed, but this is the medication that's used most often for it. Interesting enough, same, if you remember, it's the same as the atypical. I'm sorry, it's the typical antipsychotics used for severe nausea and vomiting. Some of the adverse side effects, again, you can have Parkinson-like symptoms, and cardiac dyskinesia can still be associated with the atypical, though it's seen as occurring less often. Jaundice can occur when a person has a hypersensitive reaction to it. Weight gain. So diabetes. It's interesting. Some of the more, the disorder that I talked about earlier that can be associated with typical psychotics, which is the neuroleptic disorder, where the body's temperature regulation system breaks down. That's not associated, but what is associated with it can be weight gain and a worsening of diabetes. Antipsychotics are effective for controlling symptoms. So antipsychotic drugs are useful. Over time, they help to prevent psychotic episodes, but they also, so one of the good things about antipsychotic medications is they're not only good for preventing psychotic episodes, which is the long-term purpose of them, the purpose of using them long-term, but they also are effective for treating the episodes while they're occurring. It says here, antipsychotic drugs are not generally effective in improving negative schizophrenic symptoms, although atypical psychotic drugs are more effective. But even there, they're not very effective. One other thing, just as a name, just if you look at this little thing here, approximately 4% of chronic schizophrenia are poorly controlled medicine. This is sort of the last. This is the medication, clozapine, that is used kind of when nothing else works. Like, this is sort of the last line of defense with the antipsychotic drugs. It tends to be the one that it has some more side effects to it, which is why it's not the first line of defense. But this is the one that is kind of seen when nothing else works. This is sort of the one that can be the last chance as far as still being effective. Okay. And this is just about genetic information. Okay. So that's a summary of antipsychotic medications, and we'll talk about this more at the next class. So I'll see you then.